Have you ever given someone targeted therapy, progressed, gone on to immunotherapy, and gone back to targeted therapy?
Oh, yes.
Yes,
Caroline?
absolutely.
Yes, we have.
Have you done it successfully? Let me rephrase the question.
Yeah.
Well, I don't have exact numbers, but we've done that routinely, actually. You treat, the resistance develops, you give an immunotherapy, and then what do? You go back to targeted agents. Yeah. And very often you have a response, but doesn't mean that this response would last for a very long time. It depends.
My impression is that if you re-expose them, or let's say re-challenge them, that they still have a good response, but the response duration is much shorter than giving it in first line.
Which is logical.
And there is data collected by Paul Lorigan on the global level at the moment for this re-challenge. And there is a study presented here at ESMO also. So I think, yes, it works, but if the magnitude of the benefit is the same, we don't know yet.
And so let's switch for a moment and let me ask you this question. Do you ever discuss the C word with patients? Will you tell them there's a chance for a cure with, say, immunotherapy, or if it's a good outcome patient with targeted therapy?
Yeah.
Wow.
Well, I don't use the word cure, but I say there's a good chance for you that you will have a long-term benefit, and this means that you are alive at 5 years and maybe even at 10 years. Cure is a very hard. It's very hard to achieve a cure and to prove that it is a cure. But we have a good chance to have long-term control, and this started with the EP data, and nowadays. If you say optimistically, you can say that probably we can provide a 50% long-term benefit in the patients, and here it starts with 3 years and maybe 5 years in the patient population. So this is completely different. So in the beginning, when I saw first a metastatic patient, we already talked a lot about palliative care and end-of-life measurements, and now I don't feel so comfortable with this because this is not true anymore. For
Good. Well, I think we all like that. But again, if you look at the, urban legend number one was that there is a tail on the curve with immunotherapy, but now it's not urban legend number one, it's reality. I mean, you yourself have presented some of these data.
When patients ask that, I'll tell them that we begin to have reasonable hope that we are curing some patients. So it's different than before. And the best illustration that there is a real hope that is shared, that young women, when they ask for cryopreservation of their oocytes, well, before, I was explaining them in a nice way that it probably was not really worse, because it's not like giving sperm. It's a little bit more complicated.
Of course. Yeah.
But now we do it. I mean, because we have hope that some of them will be cured. So, I mean, it's not something that I find delirious to accept this.
That's an extraordinarily interesting thought, that we now think about the sperm donation, the oocyte donation, which we were all trained to do as oncologists when we were thinking about testicular cancer.
Yeah.
Mm-hmm. Would we ever think about this in melanoma?
I think as the best examples that it's changing.
So usually I'm not talking about cure, long-term benefit, and the increased likelihood that my patient is going to die from other reasons. Because, I mean, there's also some other risk in life, and so
it's a nice way of avoiding the subject, you know? But there is a bus outside, be careful.
But yes,
honestly, when I talk about the prognosis to patients, I simply don't use the word cure, and I can't remember that patients are asking me for cure. I'm talking about now the 3 and 5 year survival data. If they are BRAF mutated, the nice 3-year survival data, dabrafenib, trametinib, the cobimetinib, vemurafenib, but also the Nivo data and from phase 1 on 5 years, the 34% 5-year survival. I tell them study results, and then they can estimate, if they belong. But I'm very restrictive to do so if I see that the patient comes with a high tumor loss and high LDH.
Oh yes,
sure.
we all agree.
I'm not discussing it in the same way. If they have good prognostic factors, I'm telling them that they have good prognostic factors. If they have bad prognostic factors, I'm a bit more conservative in my
But the longest term data are probably that Checkmate 003, that's the HODI
Yes.
data presented at
Yes.
ASCO. But
at ACR.
and ASCR. But the question is, if you have a 35% 3-year, 34% 4-year, 35% or 34% 5-year, that's a plateau. I mean, I would assume there's a chance for a cure there.
But it's phase 1, and you don't know if it was heavily pretreated patients, and these heavily pretreated patients already survived 1, 2, 3 lines of treatment.
Yeah,
So you never know. But you know, if I see the current data for Pembro, particularly the
Pembro?
006 study, it's the same, if not even a little bit better.
And,
you know?
and
Pembro
Caroline
phase
presented
one?
the
Yes, I know,
01
I
long-term
know.
data, but
I mean,
it looks at least as good.
45%.
Yeah, 45.
OS.
But you know, for first line, it's 50%. You know, for untreated patients.
Yeah.
45.
45.
45.
For first line.
And
45.
all line it's
006.
40.
So
01.
that's
3 years,
awfully
006,
encouraging data
3
that says
3
to
years.
me,
It's not public.
maybe in the future we can talk about cure to these patients.
No.
But no, I agree, it's a difficult topic of conversation. So let's